Good evening. My name is Juleen Frazer. I'm a registered nurse at the University of Arizona Global Campus, taking this Nurse 406 Leading and Managing in Nursing course with Dr. Patricia Gerst. Monday, October 13, 2025 is the day. The presentation has been named Leadership Executive Summary PowerPoint Presentation. Introduction to the problem. In a high acuity neuro ICU, timely and accurate neurological assessments are essential for detecting early signs of deterioration in patients with critical brain conditions. Our internal audits reveal that over 30% of required neurological assessments were documented more than 15 minutes late. This is an alarming statistic in an environment where minutes can mean the difference between recovery and permanent damage or death. This issue came to light after a near-miss incident involving delayed recognition of worsening intracranial hemorrhage. The delays are not isolated events, but symptoms of broader systemic issues, including workflow inefficiencies, poor handoff, and inconsistent prioritization under stress. Background of the problem. In our current neuro ICU practice, timely neurological assessments are essential for detecting subtle changes that may indicate serious complications, such as increased intracranial pressure or evolve into a stroke. These patients often deteriorate so quickly that short delays can have significant consequences. There are currently no built-in tools in the EHR to prompt or escalate overdue assessments, leaving nurses to manage these time-sensitive tasks manually in a high-demand environment. The neuro ICU is fast-paced and unpredictable, and workflow interruptions like emergent procedures or short staffage often contribute to these delays. This lack of system support puts patients at risk and highlights the need for a structured process improvement that supports real-time reminders, staff accountability, and improved task prioritization to ensure timely neurological monitoring. Thesis statement with objective. This quality improvement initiative aims to increase compliance with timely neuro assessments from 70% to 90% within 6 months in a 27-bed neuro ICU through EHR-based alerts, education, and process redesign. With that being said, to achieve this, we will implement a combination of EHR-based alert systems, standardized neuro handoff checklists, targeted education, and simulation-based reinforcement. These strategies are evidence-based and tailored to the unique challenges of critical care nursing. Ultimately, our objective is to improve early detection of the neurological deficits that patients face and reduce preventable complications while supporting staff in delivering safer and more consistent care to our patients. SWOT analysis. So, SWOT stands for strengths, weaknesses, opportunities, and threats in identifying a tool that can use to help in this matter. The strengths identified are skilled and experienced neuro ICU nursing staff, existing EHR system capable of customization, strong leadership support for quality improvement. Weaknesses include lack of real-time neuro assessment alerts, staff resistant to additional documentation, high workload, and competing priorities. Opportunities that we see we can explore include integration of EHR-based alerts and dashboards, use of neuro champions for peer support, training to improve workflow efficiency and compliance. Some threats that were identified: alert fatigue that potentially reduces effectiveness, staffing shortages that impact implementation, and unforeseen technical issues during the rollout. This slide is a continuation of the SWOT of critical care environment and the Miami Hospital Neuro ICU. With strengths, what are the company's advantages? What does the company do well? What relevant resources does the company have? We explored that the company has access to advanced neuromonitoring technologies, hospital culture focus on patient safety, leadership support, and quality improvement, with a reputation for excellence in neurocritical care. Weaknesses, what the company could improve on: inconsistent or delayed neuroassessment that led to this proposal, poor communication and lack in standardization during handoff, limited accountability and feedback for compliance with neurocheck protocols. Opportunities where the company is doing well and could provide interesting trend for company to be aware of is to implement EHR-based alerts to promptly time neurochecks, develop standardized neuro assessments, and regular training refreshers for staff through education to reinforce neuro assessment skills. Some threats that the companies face during obstacles include patient safety incidents or adverse outcomes due to these delayed neurochecks, staff being burnt out and dissatisfaction that can lead to turnover, technology such as the EHR that is poorly integrated or difficult to use that could hinder the ability to help, and organizational priorities that may shift from frontline concern to limiting progress. Looking at literature review number one, I've chosen Labuzeta et al. Variability in Neuro Assessment Practices. Labuzeta and colleagues conducted a multi-center study examining the variability of neuroassessment practices in the neuro ICU. Their research identified significant inconsistencies in how often neurochecks were performed and documented. Importantly, they found that delays of more than 15 minutes in neuro assessments were associated with delayed recognition of neurological deterioration, which could adversely affect patient outcomes. This variability was linked to differences in unit protocols, staffing challenges, and workflow inefficiencies. The study underscores the critical need for standardized neurocheck protocols and the implementation of real-time monitoring tools such as EHR-based alerts to ensure timely assessment and documentation. These findings strongly support the rationale behind our quality improvement initiative aimed at improving the timeliness and consistency of neuro assessments in our unit. The second literature I've chosen to explore is Livesay et al. Performance Metrics from Neurocritical Care Society. This study, commissioned by the Neurocritical Care Society involving Livesay et al. And colleagues, presents a set of clinical performance measures specific to neurocritical care settings. One of the core indicators identified is the timeliness and accuracy of neurological assessments. The authors stress that even brief delays in neuroassessments can hinder early recognition of neurological decline, particularly in high acuity populations such as our stroke patients or intracranial hemorrhage patients. Their framework promotes standardization of both the timing and the documentation of neurochecks, advocating for structured processes and quality tracking systems within units. This aligns directly with our improvement plan, which introduces real-time EHR alerts, compliance dashboards, and a handoff checklist to reduce delays. Their findings reinforce the need for measurable, data-driven improvements and provide a benchmark for units striving to enhance patient safety and outcomes in the neuro ICU. For literature review number three, I've used Kadura et al. Leveraging the EHR to improve monitoring and outcomes. Kadura et al. Provides valuable insights into how electronic health record systems can enhance the reliability of routine critical care tasks, including neurological assessments. Their research demonstrates that thoughtfully implemented EHR features, how such scheduled task lists, timers, and real-time alerts can significantly improve compliance with time-sensitive assessments. Importantly, the authors caution that poorly designed alerts can contribute to alert fatigue, leading staff to ignore or override notifications. To counter this, they recommend a user-centered design approach that incorporates feedback from clinical staff during the development and rollout phases. Their study underscores the importance of strong collaboration between IT, informatic teams, and frontline providers. These findings directly support the initiative, which includes EHR timers and just-in-time alerts for neurochecks, ensuring reminders are effective without being disruptive. The work by Kadura et al. Reinforces these EHR tools with well-integrated, drivable measures for improvement in patient safety. So looking at the theoretical framework for change, Paris model. The PARIS, which stands for the Promoting Action on Research Implementation in Health Services framework, guides this quality improvement initiative. The model emphasizes that successful change depends on the interaction of three core elements, which includes evidence, context, and facilitation. In terms of evidence, this project draws on clinical studies, internal audit data showing 30% delay in neuro assessments, and national performance expectation from the Neurocritical Care Society. The context is the 27-bed neuro ICU, where patients that have high acuity and clinical staff manage complex time-sensitive tasks. This setting requires workflow-sensitive solutions that align with real-world demands. The facilitation component improves, involves active support systems such as shift-based neuro champions, targeted simulation training, and EHR-based decision tools such as timers and alerts. Together, these elements support effective translation of evidence into practice. The Paris is a great idea and is ideal because it recognizes that knowledge alone is insufficient without thoughtful engagement and structural alignment in the clinical environment. Team Steps integration. Team Steps developed by AHRQ provides a structured framework to strengthen team communication and performance in high-risk settings like the neuro ICU. This quality initiative incorporates Team Steps principles to enhance implementation success. Communication is optimized through tools like SBAR, structured handoff checklists, and EHR-generated task reminders. These promote clarity and consistency, especially during shift transitions. Situation monitoring is supported by real-time NeuroCheck dashboards, countdown timers, and peer oversights for helping staff identify missed tasks or patient deterioration early. Mutual support is encouraged through cross-coverage strategies and the role of neuro-champions who provide the on-the-spot support and coaching and assist colleagues during workload surges. These champions reinforce best practices and remove barriers in real time. Leadership plays a vital role. Charge nurse and clinical nurse specialists conduct daily huddles, monitoring compliance metrics and facilitating feedback loops. Integrating team steps ensures a shared mental model, enabling safer, more efficient neuroassessment processes. Stakeholders and role responsibilities. Registered nurses are at the forefront of this change. They perform the neurological assessments and document them in the EHR and escalate findings. The adherence to the new tools and workflow will directly impact compliance outcomes. Clinical nurse specialists play a pivotal role in leading simulation training, monitoring performance metrics, and serving as liaisons between clinical staff and leadership. The IT and clinical informatics team is essential for building and maintaining the EHR base that is used for neuro checks, including timers, alerts, and dashboards. Their work ensures that technology supports workflow without causing unnecessary disruptions. Nurse leadership, including charge nurses and managers, will oversee operational implementation, allocate staffing resources, and guide cultural change through accountability measures. Lastly, HR vendor consultants provide expertise on system integration, helping tailor tools to the unit's needs and ensuring usability for frontline staff. Implementation Plan Overview. This quality improvement initiative consists of 5 integrated components. We have the EHR timers and alerts, standardized handoff checklists, quarterly education and stimulation, real-time compliance tracking, and workflow redesign. EHR timers and alerts for first-time users will prompt nurses when doing neuro checks or when they are due. With built-in escalation, if two are missed or if deterioration is noted, next, the handoff checklist standardized communication during shift change to reduce oversight. Quarterly training and simulation will build staff competence in neuro assessments and reinforce urgency in completing checks on time. Real-time dashboard would allow staff and leaders to monitor compliance by shift and identify improvement opportunities. Workflow redesign will address operational barriers by redistributing patient assignments during peak times and increasing flexibility to support adherence. Together, these interventions are expected to boost on-time neuro checks and compliance to at least 70, more than the 70%, at least to the 90%. Implementation plan, we have 4 phases: planning and tool development, staff training and simulation, our go live and early support, and ongoing monitoring and feedback. These 4 phases ensure a smooth, sustained rollout of the neuro assessment improvement initiative. In phase 1, we focus on planning and tool development. IT will work with the EHR vendors at this point and clinical leaders to build the timer that's needed for neuro check reminders and alerts. Phase 2 is centered around staff preparation. All nurses and clinical nurse specialists will undergo structured training, including hands-on simulation that will be used and identify super users and newer champions that will be trained to reinforce the new processes during live care. During the official go live period, the updated tools will be introduced on all shifts. Newer champions and additional IT support will be deployed to help troubleshoot and coach staff in real time. Phase 4 will ensure sustainability. Real time dashboard will be reviewed during huddles and staff feedback so we can have continuous adjustments and support for our plan, do, study, act cycles. So slide 15 is a Gantt chart. This chart outlines the 6-month phase implementation of the Quality Improvement Initiative aimed at increasing neuro assessment compliance. In month 1, as you can see, the project kicks off with leadership engagement, stakeholder meetings, and resource finalization. Our IT and clinical informatics team begin building the EHR timers and alert logic in the existing system. In months 2 and 3, we focus heavily on education. Staff-wide neuro assessment refresher sessions and documentation training begins, and newer champions are identified and trained to reinforce best practices. In months 3 and 4, simulation drills allow staff to practice neuro checks in real time. High stress scenarios are used while EHR tools go live by mid month of month 4. From month 4 to 6, the team begins continuous real-time monitoring, feedback, and coaching, including compliance dashboard and shift huddles. In month 5, the plan, do, study, act cycle assesses early impact and informs improvement. By month 6, a full evaluation measure for clinical outcome and staff feedback is conducted, leading to a report out and potential scaling. Budget overview, total cost breakdown. So this slide outlines the projected cost for the full implementation of the neuro assessment process improvement initiative. The total estimated cost is $835,000, covering both direct and indirect expenses over a 3-year period. The largest single expenditure is the EHR licensing cost, which is estimated at $300,000 for a 3-year contract that includes technical support and updates. Next, we have $200,000 allocated to upgrading infrastructure, which includes servers, workstations, tables for bedside documentation, and cybersecurity tools to ensure HIPAA compliance. Training and education, including workshop, simulation drills, and e-learning modules that are budgeted for $100,000. To support technical needs, $150,000 has been reserved for vendor and consultation fees to assist with configuration and rollout. Temporary staff, while we do this implementation, has been budgeted at $80,000, which will ensure coverage during go-live periods without compromising patient care. A modest $5,000 is set aside for change management materials, including communication resources and feedback tools. This comprehensive budget supports a seamless transition and system adaptation. Continuing on budget, we have the funding sources. The financial strategy for this initiative ensures that with the projected $835,000 cost is fully covered, we may surpass with 1.15 million in available funding. The primary funding source will be the hospital's 2025 capital expenditures budget, which will contribute 800,000 towards system modernization and clinical transformation. The hospital also qualifies for $250,000 in federal funding through the Center for Medicare and Medicaid Services, promoting interoperable program, which is formerly known as the Meaningful Use. These incentives reward hospitals for implementing certified EHR systems that promote data sharing and improve patient safety, which is an excellent match for this project's goal. Additionally, the organization has secured a $100,000 state level health IT grant specifically aimed at helping rural and mid sized hospitals to adopt interoperable technology solutions. These funding streamlines not only provide full financial backing but also demonstrate the strategic importance and institutional support for this initiative. The supplies can be reserved for future optimization, unexpected costs, or expansion of digital tools. Comparison to current practice. Currently, the newer ICU depends largely on paper based records and multiple siloed legacy systems, which creates significant barriers to efficient and timely neurological assessments. This fragmentation leads to manual documentation processes that are error prone and often delayed, which contributes to the 30% of neurochecks that are being documented more than 15 minutes late. Additionally, these disconnected systems hinder real-time data sharing and team communication, impeding timely clinical decision making and increasing patient safety risk. The proposed change introduces a fully integrated EHR system designed to standardize and automate neuroassessment workflow. With automated timestamp alerts, nurses and clinicians will be reminded promptly when neurochecks are due, reducing the risk of delay. The system supports real-time accessible documentation visible to the entire care team, enhancing communication and coordination. Furthermore, the new process includes standardization handoff checklists and communication tools for SBAR, ensuring consistent information exchange during shift change. This digital transformation will replace physical files with secure, centralized digital storage that complies with HIPAA regulations, improving data security and accessibility. This is a great comparison to the current workflow because, for example, standardizing EHR, if one system is using Epic, for example, and another system is using Cerner, if we standardize to the a system base wide that we can have patient information uploaded, a patient that was experiencing a stroke in a lower acuity hospital and transferred to a higher level acuity hospital, maybe a level one stroke hospital, the information can be uploaded rather than coming in with EMS with paper-based information and having to figure out the PCA. So nurses know right away off the bat what the patient is experiencing and where they stand in needing to do documentation frequency. Method for evaluating the plan. Primary outcome, timely neuro assessments. The primary metric for evaluating the success of this initiative will be the percentage of neuro assessments completed on time, specifically within the 15 minutes as this was our target for deficit. This is a direct reflection of adherence to clinical guidelines and process compliance. This data will be gathered through timestamp entries in the EHR, providing objective real-time tracking. Monitoring this metric closely allows for quick identification of gaps and areas requiring intervention. Secondary outcome measures is another critical measure and is used for time between identification of neurological deterioration and escalation to the appropriate clinical response. Faster escalation indicates better recognition and communication, which can reduce adverse outcomes. This will be tracked via incident report and escalation logs. Also, we have adverse neurological events, which include unplanned ICU transfers, cold strokes, and then we also have average length of stay in the neuro ICU as part of the secondary outcome, depending on what the patient has experienced based on their deficit and how well of care able to get based on EHR documentation. And staff satisfaction and engagement surveys will also be explored. Methods for overcoming barriers to implementation. Successful implementation faces several potential barriers. A major challenge is alert fatigue, where clinicians become overwhelmed by numerous EHR alerts, leading to ignored or dismissed notifications. Since our intervention includes EHR-based reminders for neurochecks, careful design is needed to minimize this risk. Time constraints are another significant barrier, as nursing staff in the neuro ICU often juggle multiple high acuity tasks simultaneously. Prioritizing timely neuro assessments amid competing demands can be difficult without appropriate staffing and workflow adjustments. Resistance to change is common in healthcare settings, especially when new processes or documentation requirements are introduced. Some staff may feel skeptical or reluctant to adopt new tools, especially if they perceive them as adding workload without clear benefits. Recognizing these barriers upfront will enable us to develop tailored mitigation strategies that encourage staff engagement, transition, and compliance. Expected outcomes. The anticipated outcomes of this quality improvement initiative extend across clinical, operational, and financial domains. Most importantly, we expect safer patient care by significantly reducing delays in neurological assessments, enabling earlier recognition and treatment of patient deterioration. This proactive monitoring should increase patient satisfaction and decrease adverse events such as unplanned ICU transfers and strokes. In addition, the standardized processes and EHR tools will reduce delays and increase consistency in neurochecks. From the nursing perspective, the initiative aims to improve workflow by integrating alerts, checklists, and peer support, which streamline tasks rather than add burden. Financially, the project is designed to be cost effective with an estimated return on investment within 3 years, driven by improved patient outcomes, reduced complications, and efficiency gains. These outcomes collectively support the hospital's mission to provide high quality, efficient, and patient centered care. Conclusion, call to action. In summary, delayed neurological assessments in our neuro ICU pose a significant patient safety risk, with over 30% of assessments documented late by more than 15 minutes. Our proposed quality improvement plan, guided by the Paris framework and supported by team steps, principles, integrates EHR alerts, education, workflow redesign, and real-time facilitation through neuro champions. This multifaceted approach is grounded in evidence and tailored in our unit's unique context. We expect meaningful improvements in timely neurochecks, patient safety, nurse workflow, and operational efficiency, with a positive financial return within 3 years. We respectfully request your approval and support to proceed with this initiative, enabling us to develop and deliver safer, more effective care for our vulnerable neurocritical patients. Your commitment will empower our team to successfully implement and sustain this essential change. This slide demonstrates references consulted for this implementation. I want to acknowledge the foundational literature and sources that supported the development of this quality improvement initiative. The references listed here include peer-reviewed studies, national guidelines, and implementation science frameworks that informed each aspect of the project, from identifying the practice gap to designing and evaluating the intervention. Key sources such as my literature reviews from Labuzeta et al., Kadura et al., Livesay et al. From the Neurocritical Care Society, and Weberg and Mangold's insight into healthcare technology integration were instrumental. Additionally, evidence from team steps and the Paris framework provided strong guidance for our change management and communication strategies. Thank you so much for taking the time to listen to this presentation and for your continued commitment to advancing patient care and safety. Your support is vital to the success of this initiative, and we look forward to working together to implement these changes and improve outcomes for our patients in the neurointensive care unit.